Welcome to PodTox episode 11. It is crazy. We're already on episode 11. It feels like we just started this, but it's going good. Today we have Dr. Taylor Nichols here, and he is going to be talking about how he got into addiction medicine. He is going to tell us a little bit about Matt and answer hopefully all of our questions that we have, because there's been a lot of people having questions about Matt in general, pain patients, Brixadi, which is a new medication that is going to be used kind of like Sublocade. There's all types of stuff in here. So we want to just go ahead and start off, man, with how did you get into this? What got you started with addiction medicine?
So my background, my training is in emergency medicine. So I'm a board certified emergency medicine physician. I went to medical school at UC Davis. Did 4 years of emergency medicine residency at UCSF, and then did a year of fellowship in health policy and advocacy, and then have since sort of transitioned some of my time. It was about half of my time starting a little over a year ago into addiction medicine. I've always been interested in the field. As with a lot of us, we get into this because of our lived experience, either personally or with someone that we love. And I'm not shy about talking about this, but and my dad's not shy about it either, but he has alcohol and opioid use disorder, and I have a long family history of substance use disorders, and I had a certain perspective that comes from being the child of substance use and substance use disorders. And being in emergency medicine really, I like to say, it radicalized me. It changed my perspective tremendously. I had a certain perspective of what we are indoctrinated with about control and substance use and, drugs are bad kind of dare language. And then I got into addiction medicine, and I was seeing the real life lived experience of people who had substance use disorders and who use drugs. Not everybody who uses drugs has a substance use disorder, right? And seeing that really changed my perspective dramatically. And I had a lot of conversations at that point with my dad, who was struggling with relapse. He had been sober for most of my life, frankly. And ironically, at this time that I was going through this sort of transformation in my thinking, I was helping him in the setting of his relapse. And those two things combined really sort of solidified my interest in it. And then, I finished emergency medicine training. I went out practicing in the community and sort of became more and more disillusioned with the fact that there just really is a lot of perpetuated stigma within healthcare. And that, I felt like I was constantly trying to address this on the emergency medicine side and not really making enough progress. I became sort of our go-to person in the emergency department on how to start folks on Bupe, for example, and became our sort of clinical lead for my organization that I worked for in the emergency department, and was very fortunate to have a friend, one of my best friends from medical school, who also went into emergency medicine and then addiction medicine, had been doing that throughout his training and then subsequent into his career, has done a lot of harm reduction work and helped me shift my thinking and have some of those hard conversations. He basically gave me one of his harm reduction jobs. He had worked in a clinic here where I live in Sacramento, and I was getting frustrated and sort of burned out. And he's like, just come with me to clinic and check it out. It is, something that I know you'd be interested in. And it's my balance to the emergency department and sort of the burnout of being in that setting. And it changed everything for me. It's really sort of almost antithetical, because you are emergency medicine, you're the safety net. You're catching all all comers, all the flaws of society funnel through the emergency department, right? Whether it's an actual medical issue or it's just a social issue, whether it's related to substance use or substance use disorders, it all funnels through the emergency department, and you just feel at a certain point like you can't fix the system above you. You're just trying so hard to play catch up, and being able to confront one of those major upstream issues in a way that benefits society, benefits those patients, benefits our emergency medicine colleagues. It, felt sort of rewarding. And I like to say that I don't get thanked a lot in the emergency department. We're usually there on the worst day of people's lives, right? And that's why I signed up to do it. That's what I loved about emergency medicine. But I have, in my 10 years of doing emergency medicine, now more than 10 years, I have had more people thank me or say that I changed their lives or saved their lives by working in addiction medicine in 1 year than I have in my entire life of emergency medicine. And that in and of itself is sort of this positive feedback loop, right? Like, that is satisfying for me. So yeah, it's just only grown from there. I work in a clinic 1 to 2 days a week. I teach medical students, residents, and addiction medicine fellows in my clinic, which is affiliated with UC Davis. I work in a residential treatment center, and then I work on the inpatient side to help manage patients with substance use disorders who are hospitalized. So I kind of gotten to see the whole spectrum, the entire continuum of care, and it's given me a really unique perspective and a lot of amazing learning opportunities.
That's kind of cool. And I asked the same thing out of Dr. Zona when we had her on, but what did you learn whenever you were in medical school? What did you learn about addiction, especially if you're teaching it now? That's an interesting perspective.
Yeah, so we don't really learn a lot about addiction as a disorder, right? We don't learn about it as a disease process. I say we don't, that's not entirely fair. We spend some time talking about it, but it's not framed in the same way that we talk about, say, heart disease, or kidney disease or whatever, right? And so there's an interesting conversation that's going on in sort of the academic addiction medicine physician community about how one of the issues that we face in sort of within medicine is even the recognition by others that this is a disease process, that we should be treating this the same. And ironically, we're one of the only fields that the pathology, right, the pathology being what diseases we treat, is constantly changing. There's only so many ways the heart can be diseased. We can study it, improve upon it, but there's only so many ways things can go wrong. Addiction medicine, we are constantly playing catch up, trying to see what's in the drug supply, what new disorders are being developed as a result of people using substances, and new ways of treatment, much like we find new ways of treatment for heart disease, et cetera. But we're constantly playing catch up, but in a different way, I would say, than the police or law enforcement is playing catch up. Right? They're trying to approach it from a certain carceral, punitive perspective, and we're trying to approach it from a how do we prevent our patients from dying perspective, right? And so that is where that dichotomy lies, and that is one of my frustrations in terms of the harm reduction world about the different approaches that society takes to people who use drugs or people with substance use disorders. And so, yeah, I think, I think it would be unfair to say we don't talk about it at all in medicine, but I make a point when I have medical students rotating with me to really emphasize hey, this is a disease process. It is treatable. You should learn about it. And frankly, any physician in any field that is patient facing should know about this and can do something about it, right? So I tell all of them, I have family medicine residents who rotate with me, and I tell them, like, please take my job. Like, if all of you started doing this in your own clinics, I wouldn't have a job, and that would be great, right? Like, that would mean that more people are getting treated where they should be treated, by their primary doctor who they know, love, trust, etc.
So a little while ago, they recently changed that around. Am I correct? About the fact that primary care physicians could not give medicated assisted treatment, right?
So you're spot on that recently changed.
Yes.
It's not that primary care doctors couldn't treat it, but it was very difficult. So what changed was one of the DEA requirements to be licensed by the DEA to prescribe controlled substances was what was called the X waiver. So in the Data 2000 legislation, which was proposed in 2000, I think it was actually passed in 2001, created the licensure to be able to prescribe buprenorphine. It made prescribing of buprenorphine legal. So if you go dive way back into our history, the Harrison Act in 1914 made it illegal to treat substance use disorders with replacement therapy. So you couldn't treat opioid use disorder with opioids. In fact, it was illegal to prescribe a patient with opioid use disorder opioids of any kind. So under that sort of same logic, they made it legal, right? This was a good step at the time, but it was insufficient. So they made it legal to prescribe buprenorphine to people with opioid use disorder. That's a good thing. The limitation they placed on that was you had to do 8 hours of separate training to prescribe buprenorphine. Oh. And you could only have 30 patients on buprenorphine at a time. So primary care doctors, they often carry a panel of anywhere between like 2,000 to 5,000 patients, right? How are you supposed to manage? Certainly as a percentage, we know 10% of those people going to have a substance use disorder of some sort. So now we're talking like 500 people. Of those, how many have opioid use disorder? Well, probably more than 30, right? And Absolutely. So you couldn't even have, as one physician, unless you applied for an expanded license, which you could do. But again, all these barriers. So you could apply for an expanded license up to 100 patients. And then if you did that for a year, and you were still, in good standing, you could apply for an expanded license to 275 patients, was the max that anyone could treat. And so the clinic that I worked in, started with one physician, and then eventually he got more patients and he passed his max. And so he had to bring on other physicians, literally not because he couldn't do it, because he legally wasn't allowed to treat more patients than that.
I mean, what are your thoughts on that alone right there, that they can control what you want to prescribe someone?
I think, there's so much history there that it's hard to unwind that, but I agree with you. I mean, right? Why should you have to go back over 100 years to say like, hey, why shouldn't we be allowed to treat opioid use disorder with opioids? Or why should I have restrictions on my ability to treat patients, particularly with things that are now known to be evidence-based? And not only evidence-based, but like dramatically saving lives in the setting of a what I would call a policy crisis. We don't have an opioid crisis. We don't have, a lot of people want to say it's an illicit fentanyl crisis. What we really have is a policy crisis, right? If we had the appropriate policies, we would have a harm reduction approach to what we are doing in society that would save lives. Every overdose death is preventable. So we don't have a drug crisis because drugs are morally neutral. They're chemical structures and we impart a moral value to them. So to suggest that we have a drug crisis is a moralization on society's part. To suggest that we have a fentanyl crisis is to say one specific drug is bad, which I use fentanyl in the emergency department all the time. It's a great drug, right? Like when people come in with severe acute pain, if somebody broke their leg, they're gonna benefit from getting fentanyl. If that is taken away from me, I will be deeply upset. And doing so would be another policy failure. So we have a crisis of failed policies. And one of those failed policies is the DEA interfering with evidence-based practice.
I mean, that's been the story of our history and world history for forever. There's always antiquated policies that to change them, you have to go through so much red tape, and it takes so long that by the time something is actually done about it, it's caused chaos.
Yep.
What would you do if you could just write this policy right now? What would be your first approach, I guess? Obviously, there's only so much you can put in a podcast, but...
Yeah, I mean, so I guess that question has so many layers, right? What would I do around drug policy, or what would I do around healthcare policy? I think they're deeply related, but they're definitely different. I would say, realistically, what can we do? And the realistic answer, to start with that before fantasy, is advocacy, is like getting involved, is going to your state legislature, going to your national Congress, right? So I'm involved in a bunch of advocacy organizations. One of those is the American College of Emergency Physicians, because that's my training. That's what I'm board certified in originally. So for the last 2 years, we advocated for, in 2020 and 2021, or 2021 and 2022, we advocated for what was called the MAT Act, the Mainstreaming Addiction Treatment Act. It made no progress, but that was the bill that took away the X waiver. That was the language that was included in the Omnibus Appropriations Act that was passed in January, and signed by President Biden. So once it was signed from the White House, it included the language of the MAT Act, which took away the restrictions on prescribing of buprenorphine. So I no longer had limitations on the number of patients, and anyone could prescribe it. So Marie, speak to what you were speaking about. Now anyone, any licensed, DEA licensed prescriber, physician, nurse practitioner, PA, is able to prescribe buprenorphine to anyone. No restrictions as long as they have a DEA license. So that's why, primary care doctors weren't specifically restricted, but a lot of them didn't do it.
The extra school, the extra
all the
day.
extra hurdles. You have to do 8 hours of unpaid training time just to prescribe this drug. And one of the problems with that existing for 22 years as a regulation is now a lot of physicians who have trained within that last 22 years have this associated stigma with buprenorphine.
Right.
So now they think, oh, it must be really hard to use. It must be super dangerous. It must be hard to get patients on it. There must be some reason that was a protected category. Yet there was no limitation on prescribing all the Oxy, all the Norco, all the Vicodin that they wanted, but the treatment was restricted. And so now a bunch of people are afraid of that. And I've heard patients tell me, oh, well, my doctor said that was like giving me heroin. And it's like, so first of all, the patient who told me that was being prescribed Oxys by her doctor. So it was Oxy. Oxy is closer to heroin than buprenorphine is, right? So like, first of all, the level of misinformation in that statement is just like mind blowing, because it's like, oh, I don't want to prescribe you the treatment for opioid use disorder that also can manage your chronic pain that you're being prescribed low dose oxycodone for.
So get into that. I know that there's a lot of people in the pain community that feel so deeply about this. And I agree, being a chronic pain patient myself, those chronic pain patients do need something that's going to work for their pain.
Absolutely.
They deserve adequate pain control. They
Absolutely.
deserve it. What are your thoughts on doctors overprescribing bupe for pain right now? Because why would they go to that if they could do it? Wouldn't methadone work better?
Well, so here's part of this is a regulatory problem. And again, this is all where advocacy comes in to answer Kyle's question, right? Like the thing that you can do without getting too into the weeds and also too into fantasy land, the things that we can do now is at least push for the changes that we do need. And doing that is through advocacy at a political level. And advocacy is, I always say this, advocacy is a million things, large and small. You don't have to physically go to the Capitol constantly and be lobbying your representatives. You can get on the phone and make phone calls. You can make people aware that you're concerned. And if you are aware of what the legislative cycle looks like right now, is when a lot of people are hunting for ideas for bills to be able to introduce. Because part of their ability to get reelected is around getting laws passed. And if they get laws passed, they look better and they can talk about them and utilize that as one of their next stump speeches, right? So I happen to have been involved in this, so I know really well what the cycle looks like. And I called up, or I am in contact with my local state representative's health policy person. And I emailed her and I was like, hey, I know you're probably looking for bills. Here's some ideas. And so she came to my clinic and talked to me and one of the other docs and our clinic director. And we sat down and talked through some ideas around harm reduction. And so that being aware of these things, just that you can do that, right? Who am I? I'm nobody in the scheme of our district, but I happen to know how to do this. And so I can do that advocacy. So Marie, to answer your question specifically, I think it's complicated because our doctors overprescribing bupe is a difficult question to answer because it's only overprescribing if you feel that it's being prescribed in place of or insufficiently treating a patient.
That's what I was meaning. That's where I was going with my question.
Because I fear the language of overprescribing because what happened before, certainly there was overprescribing.
And I agree. I misworded that. I'm sorry.
But no. I think this is a perfect learning opportunity, right? So what happened before was certainly overprescribing, and a lot of people got caught up in that. And unfortunately, people as humans, have a tendency towards liking things that allow them to manage their pain, escape trauma, all of that. And so when you flooded society with a drug that does that, and medications are drugs and drugs are medications, so just to be clear, we're not using that as a stigmatizing term and people shouldn't. When you flooded society with a drug that helps do that, people liked them. So the overlap, and Marie, it sounds like you fall into this overlap in that Venn diagram. There is a lot of overlap between the chronic pain community and the opioid use disorder community because those are the people who started taking opioids and were like, my brain likes this. Great. The reason that people struggle with this discussion a lot is because they don't like being associated with people who use drugs. The problem that I face a lot in the course of these discussions is telling people with chronic pain, you use drugs and that's okay. And I need you to accept that because other people who use drugs and their brain likes it, that's also okay. And so you need to square that circle in that it's okay to be a person who uses drugs, whether you have a substance use disorder or you are treating your pain.
Dependency versus addiction. People could be dependent on something. It doesn't mean that they're addicted to it.
Absolutely true. So I think that is a difficult aspect for people to understand as well. And a lot of people, and I've gotten into difficult discussions on this app about the difference between dependence and addiction. And people will call dependence addiction because they say, oh, you're physically addicted versus you're mentally addicted. That's not really a thing. Physiologic dependence is not addiction in and of itself.
Another thing that I've seen, and I talked to somebody else about this, and I don't know if it would ever be possible just because of how regulated methadone is. But the problem people are running into is, they were getting however many oxys every single month to help with their pain, and it was working. There were no issues. and a doctor had to take them off for whatever reason. It can be a million different things at this point.
Right.
And once they were taken off and put on bupe, it didn't help with their pain anymore.
Right.
Now, the other option would be get on methadone, but that's
Right.
not that easy because then you have to go to a clinic every day. And like, would there ever be any way to get around all that that red tape so that a person that just needed it for pain could get methadone in an organized fashion? Or
Yeah. So this speaks to a few things. One, you have to understand how the pharmacology of buprenorphine works and why it works for pain, but not for everyone. And this is the problem that I have when people say it's not a pain medication. It's an opioid. It absolutely is, because we know how opioids work. They treat pain. They like cut off your pain response, but they are partial opioid agonists, which means they only activate your opioid receptors, and we're specifically talking about mu opioid receptors, which are your pain receptors as far as opioids go. Your oxy, for example, fully activates your mu opioid receptors. So 100% activity, which means it cuts off the pain response. If you get a high enough level, it's cutting off a lot of that pain response.
So it's like pouring into a cup that overflows sometimes, right?
I guess that's one way to think of it. I think of it, and maybe this is just how my brain works, I just think of it graphically, right? You're getting to 100% at that receptor. Now, if you get enough of your receptors at 100%, you've got a lot of activity. Buprenorphine only activates those receptors to 50%. So it is an opioid. And I think this is a really important point, because I have a lot of patients who come into my clinic, they've been on buprenorphine before, and they're like, I just don't want to take an opioid. And I'm like, you are taking an opioid.
Right.
It's not the same kind of opioid. It's a partial opioid, but it's an opioid. And then people are like sort of astonished. They're like, well, why did my doctor lie to me? Well, they're not necessarily lying to you. Some of the doctors just don't understand it. Again, going back to like the X waiver and making it super difficult and making people not understand it. So there is a lot of education that needs to happen around this, both to physicians, to prescribers and Ps, PAs, and to the public that are have OUD, that are considering getting on into treatment. A lot of MAT in general, and MAT, so to be clear, MAT is medication assisted treatment, which I don't love the term, but that's what we've sort of socially accepted as addiction treatment with medication. A lot of MAT is substitution or replacement therapy, using different versions of the drug that somebody had a substance use disorder to, that is longer acting and safer. Buprenorphine as a partial agonist is safer than full agonists, because you really would have to try hard to overdose on buprenorphine.
Can we talk about the ceiling effect? I made a video about this that you
Yes.
chimed in on before.
Yep.
We got a lot of feedback about that.
The ceiling effect is this idea that because it is a partial opioid agonist, if you activated every single receptor in your body, you would still only get to 50% opioid activity. And for someone who is opioid tolerant, that is, or who has, regularly used opioids, whether or not you have a substance use or an opioid use disorder, that is not going to be enough for you to get high, for you to stop breathing. In fact, if you are not opioid tolerant, you still probably won't stop breathing unless you have something else in your system that is a respiratory depressant or decreases your breathing. And so, a lot of this, and again, I may be getting ahead of myself, but like the way opioids cause you to die and cause you to die in the setting of overdose is they cause you to stop breathing. Buprenorphine, and the way that happens is because they get through the blood-brain barrier, and then they activate your central nervous system and your respiratory center, which has mu opioid receptors. And like I said, the mu receptors like turn down or cut off that response. Well, if you cut off your breathing response, it's generally a bad thing. If you only activate that 50%, you may get really sleepy, you may slow down your breathing, but you're not going to stop breathing. And so there are case reports of people taking insanely high doses of bupe as an attempt to overdose, or There's one story about a case report about somebody who took a month's worth running from the police, and was hospitalized, but never overdosed, like never stopped breathing, right? So to understand why physicians started prescribing more buprenorphine rather than full agonists is because it is safer, because you can't overdose, and we're seeing a crisis of overdose deaths in a sense. And so that's why that pendulum swung. Like it's hard to say that that is an overprescribing problem as much as it may not be clinically adequately managing an individual person's pain. But the suggestion by some folks in the chronic pain community that it is not a pain medication is like fundamentally pharmacologically untrue. And I need that to not be stigmatized, because I'll tell you what, the alternative right now is to be cut off from any opioids. And so I would rather that people at least have access to bupe. And the problem that I see often when people say that is they aren't getting high enough doses. So the FDA sort of arbitrarily, I can't say arbitrarily, the FDA set this sort of threshold at 24 milligrams. This was back when heroin was the primary drug in the opioid drug supply, along with prescription drugs, right? Those were certainly much safer and didn't create the same level of tolerance that fentanyl does. Fentanyl leads to this really high tolerance for a few reasons, and I can get into all of the like pharmacology of it, but I don't want to get too into the weeds here. But to say that fentanyl creates a super high tolerance, and people who take really high dose prescription opioids, full agonist opioids, can also develop a really high tolerance. Those people may need, just to satisfy enough opioid receptors, higher doses than 24 milligrams. In fact, a lot of my patients in clinic who have been using fentanyl or using high dose prescription opioids, I need to start them or get them up to 32 milligrams, if not more.
Now, Dr. M's touched on this when she was in our podcast as well. She said that when it comes to pain and like somebody having pain, she suggests it more frequently for pain than like twice a day or whatever. Like break it down a little bit more.
So the pharmacology here is interesting, and this is also true of buprenorphine. So, or of methadone as well as buprenorphine. So, I'm trying to think of the best way to explain this without getting like too focused on the way things bind. But so we talk about in medicine, in pharmacology, the affinity or the strength at which something binds to the receptor that it targets. So you have a chemical structure, different chemical structures fit differently into the receptor, and they bind more strongly or less strongly, or more strongly or weaker. But that is kind of a misnomer to describe it as strong versus weak. It's the way that people are able to understand the most. But what is really happening is that a chemical will bind to a receptor, and it will occupy more time in that receptor, tightly bound, and otherwise it becomes bound and unbound as it's circulating through your body. Now, the time that it is tightly bound in that receptor is the time that you're going to get the most analgesic effect, or it's going to provide the most pain control. Buprenorphine has a very, very high affinity for the mu opioid receptor. That is the reason that it can cause precipitated withdrawal. It's the reason that it will have this blockade effect for other opioids, because it is more tightly binding to the opioid receptor than almost all currently available opioids that are out in the drug supply. Carfentanil is one to look out for because it does have a somewhat higher affinity. But again, all of these, and also buprenorphine binds more strongly than fentanyl. It binds more strongly than naloxone. So that's an important thing to consider in terms of, and I'll get back to this in terms of like Suboxone and naloxone being included, and people thinking naloxone is the thing that's causing the potential for withdrawal. It's not. It's the buprenorphine, because it binds more strongly. And again, when I say more strongly, is it binds tightly for a longer period of time, and that time that it's tightly bound in the receptor is the time that other opioids can't jump in there and act. And that is when you're providing the most pain control. So what does that mean? If you, in that period, the half-life of buprenorphine, we're talking is over a full day, like 30 hours. But the time that it's tightly bound in that opioid receptor, we're talking like the 8-hour range. So it's much shorter than the half-life. So say 8 hours-ish on average, it's tightly bound. That's when you get the pain control effect. And then the rest of the time it's just circulating in your body, and it's binding and it's unbinding. And while it's bound, it's super tightly bound. And if you have enough in your system, there's enough that's binding and unbinding, binding and unbinding.
So many people get scared when it comes to surgery on medicated assisted treatments for that reason that you're just saying right there. If you have to have surgery on medicated assisted treatment, so many people are like, oh my God, I have to come off of my subs because I'm going to get precipitated withdrawal, when that's actually not accurate information.
So that speaks to the directionality. And so the pain control effect is, wow, that's super tightly bound. If you space out the doses, say 3, maybe 4 times a day, then you're going to have that tight binding throughout the entire day. So if you're sort of stacking them, if you take 4 strips of 32 milligrams and you take 1 4 times a day, that is going to have more pain control effect than if you took all of them in the morning, for example, right? Because you'll have that benefit for say 8 hours, maybe even 12 hours, if you're lucky. Then it's not going to work the rest of the time. And so when people say, well, it doesn't work for me for pain, it's because nobody's explained to them how to use it for pain, and because they're probably not at a high enough dose. Because if you're only on 1 a day, which a lot of people are like, oh, well, you just need to take 1 and it's an opioid. It's like, no, like you need people to be on, probably for chronic pain management, 4 a day, to take 1 every 6 hours or so, right? And so that is part of the reason why people will say like, oh, well, it's not it doesn't work. It's like, no, it's not enough, and you're not getting it dosed correctly. And the reason why is because the doctor who's prescribing it probably doesn't actually understand the pharmacology of how it works. The same thing, by the way, is true of methadone. And so to go back to Kyle's question really quick, the complications of the ability to prescribe methadone, if you are a person in that overlap with chronic pain and opioid use disorder, right, you will never be able to be prescribed take home pain. Like, so if you get methadone for pain, it's a pill. Most people don't realize that because all they know is the liquid methadone that you get in clinic. Well, we have federal regulations around treating opioid use disorder with methadone, which again, this goes back to the Harrison Act. And if you have opioid use disorder, you cannot be prescribed those little pills. You get the liquid form once a day to take once a day. Even if you get take homes, it's liquid form to take once a day. But the same thing is true of methadone. Now you can get higher effective dosing. It's a full opioid agonist. So you can get more analgesic effect with methadone. The problem is, if you have chronic pain and opioid use disorder and you can only take it once a day, you go to the clinic.
Yep.
Okay, so say you make it through the clinic process, you go to their groups, and then you get take-homes. But you still only take it once a day. You're still, in methadone, that binding, it has less binding affinity than buprenorphine, which means 2 things. It's binding less strongly, which means it's activating that analgesic threshold for a decreased amount of time. So we're talking like 6 hours, 6 to 8 maybe. And so that is where methadone, unfortunately, right now, the way we are allowed to use it is not as good of an option for pain necessarily than bupe. So yes, it is a full agonist. Yes, you can get higher levels with it in terms of the pain effect, pain control effect, but if you have opioid use disorder, you cannot also be taking that multiple times a day. And that is deeply unfortunate to me, because we can't use it to treat those patients. There is a bill in Congress right now that I have advocated for, that the American Society of Addiction Medicine is advocating for. So when people from the chronic pain community say that we aren't doing enough for them, we are literally trying to be able to do this, to liberalize the prescribing of methadone, right? So then you can take it however you want it. You can take it at home 4 times a day. And the reason that we're able to do this is because a natural experiment happened in COVID when we started to have lockdowns. All these patients who were expected to come to clinic every day couldn't come to clinic anymore. So what did we do? We prescribed it. Shockingly, which I say with the utmost sarcasm, fewer people died in relation to the overall overdose deaths with methadone in their system than prior to COVID. That's the concern, is that, oh, well, it's going to be sold and people are going to overdose on it. And I have a friend who overdosed on methadone who was not an opioid tolerant person. So as somebody who has personal lived experience around this, I get it. At the same time, I think we should be able to do this to treat pain. And he still overdosed in the setting of all of these restrictions. So it's not helpful to have them. So I say that with that in mind when people are going to come at me and say, but what if it gets sold and then somebody overdoses? Yeah, this kid bought it and then used it and then died. Don't tell me about how things get into the illicit drug supply. I get it. But if, as we prescribed it, people stayed in treatment longer, fewer people overdosed and died, you had higher retention rates and better survival rates. Why would we not do that thing then? Because then all of a sudden, oh, well, COVID restrictions are over, so everybody's coming back to clinic, and now you can't prescribe it again. And so there is a bill called the MATA Act, M-A-A-T-A, that is in Congress right now to liberalize prescribing. So that is, again, where advocacy comes in, that can literally change the way we are allowed to treat patients, because it's a policy problem. And that is what I want people to understand when they're attacking me. It's these are systems level issues that I can't fix. I'm trying, but I can't change it myself. Now, and to specifically address Marie's question about well, what about if you need to have surgery? There are a few ways that we can address this. One is if you know, right, if it's not an emergency surgery, it's not like you broke your leg, your bone's sticking out and you got to go straight to surgery. Okay, that's one thing. If you are say you're having a hip replacement and you know months in advance that that's going to happen, your doctor or the orthopedic surgeon, if they're comfortable, or a pain management specialist, if they're the ones who are involved, can taper you off of bupe and put you onto a full opioid agonist so you don't have that blockade effect from the buprenorphine. Do you have to do that? No, it's up to patient preference. In my clinic, I feel comfortable doing that, even though technically I am not a pain management doctor. I'm an addiction medicine doctor and an emergency medicine physician. As an emergency medicine physician, I feel very comfortable with drugs, right? I also feel that people deserve to have the treatment that would work the best for them. And I feel comfortable prescribing people with opioid use disorder opioids. I literally do that, even though one is buprenorphine and methadone is a full opioid. It's different than prescribing everyone just oxy, but I do transition patients to oral morphine, to oxy, if that's what they want and their orthopedic surgeon doesn't feel comfortable with it or doesn't understand it. I've done that for patients in my clinic, just so that their last dose of bupe needs to be 4 days before surgery. So if you know at least 4 days in advance, then you can fully have it out of your system, because of that long half-life, it gradually has to come out of your system. And so you can be on whatever full agonists you want during and after surgery if you get it out of your system. Now, there are options to stay on bupe and continue using that at high doses The problem that comes for me with that is that a lot of my patients are already at 32 milligrams. Now, if we look at the sort of normal distribution of people in that exist in the world, of adult humans, you are getting to about 95% of their mu opioid receptors at 32 milligrams. So there's not a lot of wiggle room above that. So when you're talking about ceiling effect, it's gonna fall somewhere between 30 and 40 in like a full-size adult human. And so yeah, I have people on 40, I have people higher than 40, because there's always a little bit more room. It's just that the curve starts to flatten. The benefit you get from going up is smaller, but it's not nothing.
See, I hear you saying that you're willing to do these things for patients. You're willing to adjust. Not every doctor is willing to do those things. I know the clinic I used to go to only went above 16 milligrams if you're pregnant. That was it. Right. Bottom line, nothing above unless you're pregnant.
And that's doesn't fit with that doesn't even fit with the DEA guidelines. I mean, yes, is the DEA a problem? Sure. But that's not even the problem in this case, right?
It's not that they aren't willing to. They literally don't understand how to prescribe it the right way. Right. So it's a catch.
They literally told me that they're not allowed. They're not allowed to go above that. And I see it here in these comments as well. So many people are saying their doctor tells them 16 milligrams and that's it.
And that's what I mean when I say that people saying bup is not a pain medication are fundamentally misunderstanding, and then they yell at me because they're like, well, that's what my doctor said. And it's like, don't yell at me, I'm not your doctor, but your doctor's wrong.
Right.
Like that's
absolutely
right? But I have some patients who are even above 40, like chronically, because I got them up to 32, which is sort of a normal dose range, but they're people who have chronic pain and who have used what started with heroin for a long time and then transitioned to fentanyl, and they just have a super high tolerance and also have terrible chronic pain, which was also why they were using a ton of fentanyl. Right. And so it was like, oh, 32, you're still feeling pain, you're still feeling cravings. Okay, like, let's go up, try 40. 40, doing better, cravings are gone, but like still having pain. Okay, let's go up to 44. Okay, and then like hit a point where, right, because I'll explain, like, we may get a marginal benefit, but once you get to 32, that's where people are talking about, oh, well, there's a ceiling effect. You're hitting 32, 40. Now you're really, when you're at 40, now you're talking like you're really in the margins, like you're getting anher half a percent.
When you bite those high doses like that, right, above 32, is there anything that you have to do insurance-wise? Like, you don't have to show, like, proof. I'm sure, because I used to work in medical billing. Like, I'm sure that you had to show proof that they were a previous chronic pain patient. Like, are there certain parameters guidelines?
So, this is, again, where the policy is the problem and where advocacy is needed. I have problems getting patients above 24 sometimes, which just makes my head explode. I have probably angered almost all of my local pharmacists from yelling on the phone with them. I actually had a neighbor tell me that I was in my backyard and had a neighbor check in because I was just losing it. Because I feel like it's inappropriate for them to
dictate.
This was a situation where a person's insurance would cover it, but they were like, well, you don't understand the medication, we can't go over 24. And I was like, I'm a literal doctor who specializes in this. You don't know what you're talking about. And they're like, well, this is my license, I can't do it. And I'm like, absolutely not. That's not true. One, you're not going to lose your license over this. Two, so this goes back to concerns, and this is what I have talked about before. All of these opioid lawsuits against the Sackler family, against Purdue Pharma, against CVS, Walgreens, like, I understand the frustration. I understand the anger. I'm angry about it. These are having, and will have, and are already having devastating consequences in terms of patient access.
Now, the pharmacy, we did want to touch base on this other question today about, is CVS and Walgreens going on strike? Because I've seen videos, I posted videos, don't want to scare people, But
Yeah.
what do you recommend patients do? November's coming up.
This is so hard because they're going to close, and part of the reason is because they were involved in distributing opioids, which is why they've told their pharmacists, you can't do this. And these are like from the top down policy issues. We have a pharmacy that my clinic writes for so many patients above 24 milligrams, and they get yelled at by, whomever above them, that they can't do that they literally told us, whether it's for bupe or not, they're not going to fill any prescriptions from our clinic anymore. And mostly because probably me argued that with them so much. They were like,
love that,
"You're
though.
done.
Thank you.
We're cutting you off." And I was like, "Fine, F you. Like, we're not going to send you any business. I don't care. That's not my problem." Unfortunately, it happens to be the CVS that is like physically most proximal to us, which is also why they were getting the most prescriptions from us.
Absolutely,
that
makes
they
sense.
didn't like. But it's, they won't do that, and National will yell at them about it because they got sued for hundreds of millions of dollars for participating in the distribution of opioids when we were dramatically increasing our prescribing in the late 90s, early 2000s, up through 2009 really. And that has bit them really hard, and now we are facing the repercussions of that. And so now some of them won't give the medications, some of them are closing stores, and in areas where there are not a ton of options, I happen to be very fortunate that I'm in an area where all of the big chains have a lot of stores, and there are a lot of small non-chain pharmacies.
Now, don't they have a cap on the amount of scripts that they can fill at mom and pops? Because
so everywhere it does.
Another issue, because they're going to get flooded, but they're not going to be able to accept new patients, correct?
Another policy level issue there, they can only keep on hand a certain amount of opioids at any given time. Yep. And buprenorphine is still categorized in the same category as full opioid agonists. So they have to decide what that circle, that whole pie, is going to look like. And then they're like, okay, this much can be bupe, and this much can be oxy, and this much can be norco, and so then it's not a maximum number of scripts. It's the amount of opioids they are allowed to have on hand at any time. So then they get shortages because, say, I write for a month of 4 bupe tabs a day.
Yeah.
There goes a bunch of their bupe supply. And so oftentimes I'll be negotiating with pharmacies to be like, hey, give them half now and they'll come back in 2 weeks because they just need it. And because they'll call me and they'll be like, we can't do that. Now for some of these chains, they're able to manage the amount of opioid, right? Because they'll have multiple within a region and they'll say, oh, well, we don't have it, but another pharmacy does. Now, that was tricky with controlled substances because in the past, say I prescribe you antibiotics to CVS. Well, you could go to another CVS and they could pull up that prescription and just give you the antibiotics. Up until this year, and the law was changed, but a lot of pharmacies still don't know this, and I have to argue with them about this as well. They are now legally allowed to move that or distribute that prescription for a controlled substance to a different pharmacy within the same chain. It used to be if I wrote a prescription to a specific CVS, only that CVS could do it, and they'd be like, oh, well, we'd have to get bupe from the other CVS, and that's going to take some time. And it would be like, well, why can't, patients would be like, I don't understand. Why can't I go to that other CVS then? And it's like, oh, well, I have to rewrite the prescription, which I can do, but it's just a bunch of hurdles and a bunch of phone calls and frustrated patients calling me being like, I don't understand. And it's like, I'm sorry I didn't create the system, and I will do that. And I go as much above and beyond as I can. I keep my phone on me all the time. So when, and people can message me or my clinic at any time. And so it'll be like 8 o'clock at night, and they'll be like, the pharmacy closes at 9 and I can't, they tell me I have to go to this other place, but you have to rewrite the prescription. It's like, okay, I'll do that. Let me get to the computer. But now, legally, pharmacies can do that. Will they? It's a question. It's up to them. With pharmacies closing, you aren't going to have all those options anymore. And if you're in a region that's more rural or doesn't have a bunch of pharmacies, you may be without any pharmacy in your area.
I agree with that. And lead into another question that we had is if people are, this is what made me want to get on Sublocade and get off of MAT, because I saw this coming from last year when I started having problems getting my script filled. What do you think about like Sublocade and Brixadi? Do you think that they're going to be better options because of the pharmacy issue going on?
Personally, I hope so. I'm a huge fan of Sublocade and Brixadi. Right? These are great MAT options that people can be sustained on if they want. So I have, some of this is personal bias, and I'm sure Invidier, which is the maker of Sublocade, won't like me saying this, but I don't really care. The way the package insert for Sublocade is written is that you get 2 injections of 300 milligrams and immediately drop to 100, and then after, I think it's 2 or 3 doses, you're off.
You do the split dose like I did, correct?
I give people whatever they
don't
need.
like
I
it.
keep people on 300 as long as they need until they feel comfortable and stable to go down. And then I actually have a bunch of patients who they'll say, okay, divide it into a 150 and 150, and then we'll do that, and then go to 100. Or I have a few patients who they're like, I don't want like the psychological effect of trying to taper on like sublingual tabs was the hardest part for me before. And so I just don't want to know.
Oh, I love that. That's an excellent idea.
So I just don't tell them. They told me specifically,
that.
don't tell me, just do less whenever so they're like, tell me they're ready to go down. And they're like, just don't tell me when you do it. So I'll like maybe wait a month so that they feel stable after they've told me that. And then I'll just do 200 instead of, well, I mean, it's an approximation, right? So right. It's 100 milligrams per half ml, and it comes in 1.5 mLs for 300. And so I'll just do approximately 1 ml instead of 1.5, and then I'll do a little bit less, and then a little bit less.
I did the 150. I went from 300, 300, 150, 100, 100. Ordered a 6 shot, and my doctor is going to hold that for a year. That helps my mental aspect because I know that shot is sitting there. And
whenever I order 300 from so you have to order it through a specialty pharmacy. You can't just order this from CVS. It has to be a place that actually like distributes this, and they send it to the clinic, right? And it has to be, so Sublocade has to be refrigerated. Mm-hmm. So whenever I write the 300 milligrams times 4 refills.
Love it.
I'm not going for 2. Or really 1 refill, because that's what Invidier says. And it's so problematic to me that they literally wrote all of this in their package insert, because then those are the things that become complicating later on when pharmacies want to say, oh, well, that's not how it's supposed to be used. And I'm like, well, that's how I use it.
Have you had anyone that's withdrawn from Sublocade? Because I've talked to multiple people that did, and it was like weeks and months and all this stuff later, and all of a sudden they just slowly started feeling worse and worse. And I've had a lot of doctors say they hadn't heard of that. Dr. Ims was one.
Yeah. So every withdrawal syndrome is proportional to the half-life of the drug, right? And so this is why people talk about like, oh, well, subs are so much worse. They're harder to get off than fentanyl. Well, yeah, because by definition, the half-life is 30 hours, and fentanyl, it's like a few, right? And your peak, it's also directly proportional to the spike of the drug. And bup is really like low, stable, long-acting. Fentanyl is like a spike and a crash and a spike and a crash. Well, what do you think the inverse of that is going to look like? Directly proportional. You're going to have a much worse withdrawal syndrome for a shorter period of time. It's exactly proportionally inverse. So yes, fentanyl will be much easier to get off of as far as time-wise. It's going to be a worse withdrawal syndrome, but for a shorter amount of time. Getting off of subs, because the half-life is 30 hours, you're going to have a prolonged withdrawal state that will likely be less severe. And then Sublocade, their half-life is 30 days, not 30 hours. So your withdrawal syndrome is going to be really long.
But I have to say, I feel amazing. I personally feel amazing. Like, I literally walked away withdrawal free.
Right.
To me, it was my freedom. I found my freedom in that.
Right. And so the withdrawal state is only going to come if you have not reached an adequate steady state. And you have to, when you take something with such a long half-life, you sort of stack it. And so the first 300 milligram shot isn't going to get you there. Correct. You're never going to like fully reach that steady state. It's really not until the second one, and for some people even longer. Once you reach that steady state, the super long half-life of this, it's going to be such a slow taper off.
Right.
Now, I've only had one patient who I know had a mild withdrawal syndrome from it. And this was the funny part to me. He came into clinic. I told him, I was like, we had done 100, I don't know how many times, I think. So what I do in terms of when people get to 100 is I start spacing it out, because it's really a lot harder to even go down on the dose from there. But I'll space it out, say, see how you do it. Instead of 4 weeks, do 5 weeks, and then do 6 weeks, and then do 7 weeks. And maybe 2 months if you still need it. This is only if people are wanting to get off, right? If they want to stay on 100 forever, fine. If they want to stay on 300 forever, fine. And this is, I'll get to the difference between Sublocade and Brixadi, but when people get to a steady state on 100 and they're spacing it out like that, eventually it's just you're gonna have this super long, slow,
just off,
like taper. Yeah. And then you're just off. And so a patient that I had, I told him, we hit almost 2 months, I think. And he was like, I think I'm going to be good. Like, I'll come back if I need you or whatever. And I was like, cool. Like, good luck. Peace out. See you later. Let us know how it goes. And it was the first patient I had who ever came back. And he came back because he was like, I haven't taken anything sublingually. I haven't taken anything by mouth in over a year now. And so I didn't realize that this is what withdrawal felt like, because I didn't think of it, I haven't had any Sublocade in 4 months, which makes sense for the half-life, because it takes about 4 half-lives for something to be out of your system. And he was like, I couldn't sleep for 3 days, and I just felt really anxious. That was it. No physical withdrawal symptoms other than just this anxiety that prevented him from sleeping. And so I gave him some withdrawal management medications, just to ride it out for a little bit longer and help him sleep and manage the anxiety, and said, and I think I wrote for 2 weeks. I said, if this is enough, come back. We won't even bill it as a visit or anything. Just I'll just write you for more. And I never heard from him again. So I don't know about a true severe withdrawal syndrome. Because if you're doing it right, you shouldn't get to that point. You may end up like this patient, having just the mildest, as the last of that bupe comes out of your system, you might get a little mild sort of insomnia, agitation, anxiety as you start, as all the opioid receptors now unoccupied.
What has happened with the couple of people I've talked to, they know what withdrawal feels like. So once they started feeling that very mild, so much of it is mental. So they put themselves in withdrawal.
And then it's just then spirals, right? The mental game is always this spiral. Oh no, it's going to get worse. And then you anticipate it's going to get worse. So it does get worse. So Brixadi. So here's the other thing about Sublocade. In the package insert, it says you cannot start someone on Sublocade until they've been stabilized on sublingual buprenorphine for a week.
Yep.
So we can't use it as an induction med, although there's research being done on using that straight in the emergency department right now, which is super fascinating to me. And also using ketamine for the management of potential precipitated withdrawal, which I love as a emergency medicine physician. We love ketamine. It's a magic drug. It works for everything. And if you understand the pharmacology of how it works, it makes sense that it would manage withdrawal symptoms. So the research that's being done is like getting people on ketamine and then hitting them with Sublocade, and then seeing how that goes and doing this sort of induction. I think there are some protocols that are just like getting people straight onto Sublocade, no ketamine, and it's going okay. The problem is that will not be accepted until the package insert, until NVIDIA changes the language. And they could do a bunch of things that I'm sure if they were willing to listen to me, that I could advise them that would improve their product, but they probably won't. Brixadi does not have that language included. The other difference with Brixadi is that they have a direct conversion chart. 8 milligrams is this much, 16 milligrams is this much, 24 milligrams is this much. So if you are on 24 and you want to stay on 24 milligram equivalent, this is the dose that you use. And they have 1 week and 1 month for each of those, which I think is awesome. I did tell them.
Somebody want to do weekly versus monthly. Why?
I asked them that, and they didn't have a great answer for me. The only thing that I could think of as a good reason in my mind that I would want to use it, and it may not be the patient's reason for using it, would be as an induction medication. Okay. So somebody comes into my clinic and they're like, I can't stop using. I just need to be on something right now that's just going to block. It's like, okay, a week. And then we can adjust the dose more easily, because once you hit them with a month, you're kind of stuck. Like, yeah, you can stack on top of that. But one, you're getting yourself a little bit stuck and you're going to have to use sublingual on top of that. And also, I don't know how many pharmacies would love the idea of like, well, we just gave you a month's worth of the medication and you want another month to use a week later?
I wanted to see if you've ever had this. I have a few people that recently reached out to me that were on Sublocade. They were doing well. They sabotaged themselves by taking their doctor wrote them for a whole month's supply. It's about like, when I did it, I was very cautious about substituting. They literally got themselves hooked back on subs because they kept taking them.
I would couch this a certain way, or frame a certain way. So I do write people when I transition them onto Sublocade, especially that first month. I'll write them for a full month's worth of their subs.
Okay.
So when they get on the Sublocade, like I said, it may take 2 or more months to reach a steady state. And a lot of people will say, oh, I only needed I'll call it supplemental. I only needed the supplemental for like the first 3 days while I was sort of getting ramped up. And then kind of by the end of the month, I started feeling I took a couple more. I do have a couple patients who it seems like they just don't metabolize. So the way Sublocade works is it creates this matrix. And that's why you get this little like ball of gel. It's like molasses. It's so thick. And then when you inject it, it forms a matrix that your body breaks down to distribute the naloxone or the buprenorphine into your system. And Sublocade does not have any naloxone in it. Brixadi doesn't have any naloxone in it because you don't really need naloxone with buprenorphine. But Brixadi doesn't form that matrix. It's a nanoparticle technology instead. And so your body metabolizes that differently. And so I think it's going to be a really useful tool because, like I said, I have some patients who I truly believe they don't metabolize it very well because I can still feel more of that nodule of Sublocade than I do in most other patients. And it's like, and so they're like, doc, I was still using, they go from 4 tabs a day to 2 tabs a day. But it's just what they need to actually get the same steady state of buprenorphine in their system because they're just not adequately metabolizing the Sublocade.
You think it has to do with the amount of belly fat with the Sublocade sometimes?
Yes. And there isn't really good data on this, but I am convinced
I believe it.
Of this based on anecdotal experience, which is not very good evidence, but it's probably, and I might be saying this opposite of what you were going to say, the people who have had less belly fat have had a harder time with the injections. The people who I have one patient, who is super fit, and I joked with him about injecting into like each one of his six packs.
Yeah.
Because he was like, well, it looks like lopsided now. I was like, dude, I'll just do the other side next time. But he's like, with patients who are super fit, I just don't think they have as much fat there to help break it down. I don't know exactly why that is, but I'm going to work with him on transitioning to Brixadi. The one big limitation, and I can't do it yet because Brixadi doesn't make a 32 milligram injection.
Wow.
And the reason for that is because of this FDA threshold. That's not a law. It's just like what they think people should be adequate for what people need. But also that was based on heroin, right? When people were using heroin and prescription pills, which often they didn't have as much built up tolerance to opioids as they do with fentanyl. And so, and this goes back to the policies around the way we approve drugs and the FDA's process. So Invidior was first to market with Sublocade. Well, they got essentially a 5-year protection. Nobody else could come to market with an extended release injectable buprenorphine. So Brixadi was developing and doing their research. Their research was based on, they started doing their research in 2014, right? So all of their data is from pre-fentanyl.
Wow.
And so that is why they were like, oh, well, we're seeing this significant beneficial effect in patients at the 24 milligram mark. And the FDA says that's the threshold. And I explained to them, that's not the case anymore. And they were actually a little bit surprised by that. I apparently was the first person to tell them that most of the patients I start now are at 32. And so I was like, how am I supposed to use Brixadi if you don't have a 32 milligram threshold here?
Now, what about coming from methadone? Because I get so many questions. Kyle, I know you do as well. With people that are on methadone that would like to either switch to Sublocade or Brixadi. I know that you could do the Burmese method for Sublocade. A lot of people don't understand that.
Yeah.
I kind of want you to touch base on that.
Sure.
What about Brixadi as well?
So, so you can go from methadone to Sublocade or Brixadi. So it's a little bit tricky transitioning from methadone because methadone's half-life is up to 60 hours.
Okay.
Really long acting medication, right? And so you have to wait until someone's truly in withdrawal before you give them bupe. And like we're talking, they're really falling off the curve here before starting them on buprenorphine. Or you can do a gradual microdose taper, which isn't always the Bernese method. The Bernese method specifically is continuation of use of a full agonist opioid while you cross taper up onto a partial agonist.
Okay.
So say for people who are using fentanyl, which is sort of the easiest example, they continue using fentanyl the entire time, but because the binding affinity is lower than buprenorphine, the bupe gradually builds up in their system until all of their receptors are occupied with bupe instead of fentanyl, and then the fentanyl isn't really having that much effect. And I tell them, you're at the right dose when you can't feel your fentanyl anymore. People will often try to taper the methadone down as low as they can. I try to, so if the patient is willing to do that and come down gradually on their methadone, then that will make it easier to transition onto buprenorphine. And you will be definitely easier to get them onto extended release injectable buprenorphine. But if they're like, they come in to my clinic and they're like, I last dosed my methadone, it was 80 milligrams and I dosed 3 days ago and now I'm in withdrawal. Be like, okay, that's the point where to me, I would start doing a microdose taper.
Right.
And they could either start taking less and less of the methadone if they want to do sort of the Bernese method, keep a full agonist, or not use any more methadone and then use withdrawal management medications because they're going to continue to be in withdrawal as you gradually ramp up the bupe, and so you don't precipitate withdrawal.
And do you
No.
monitor them more closely? Like if you have a patient that wants to jump off at 80 milligrams and wants to do this, do you make them come into your office more frequently just to set eyes on them?
No, I mean, people have easy access to me,
Okay.
or my patients do. So, I had a good example is I had a patient who did this recently. She wasn't on super high dose methadone, but we were sort of cross tapering, and so I talked to her a couple times throughout that. Called my clinic. They just sort of send them to they can like send them directly to my cell phone, and so we sort of talked through it. There was a point where she felt that she had precipitated withdrawal, but I'm fairly convinced though that a lot of what we consider precipitated withdrawal is actually just worsening withdrawal and not tapering up fast enough. So like you can get pretty bad withdrawals once that methadone's really coming out of your system, especially if you're on fairly high doses. Precipitated withdrawal, particularly from methadone, is like pretty severe. So we don't want to precipitate withdrawal, but I tell patients if they're not gonna cross taper with the Bernays method and they just want to gradually titrate up, you really need to pay attention to your withdrawal syndrome and taper up more like I'll give them a guideline, right? It's like 1 week. But if you start to feel worsening withdrawal, you need to start taking more. And that can be counterintuitive. And that's why I'll tell people, right? Like telling them to come into my clinic won't necessarily help them at the time that they need it. So I'll just tell them to call me.
Earlier, you mentioned carfentanil having a higher binding affinity than fent. So I've talked to a lot of people also that have gone into detox or they wanted to start on subs or whatever, and it's been like a week, and they take the subs and go into precipitated. What is there any way to like measure this? Because none of it's regulated, so it's like, what do you do?
Theoretically, if you're using carfentanil, and some people in my clinic are knowingly using carfentanil, you shouldn't really be able to precipitate withdrawal unless you're using fentanyl and carfentanil, or it's fentanyl mixed with carfentanil. You can kick fentanyl off the receptor with bupe. You shouldn't really be easily able to kick carfentanil off. And then, there's like a whole tangent to this is like we're starting to get nitrazines in the supply and then xylazine. Those don't bind to opioid receptor. Well, nitrazines bind to opioid receptors. Xylazine does not. But so the precipitated withdrawal is probably around the fentanyl that they've been using. If it's not purely carfentanil, and you can precipitate withdrawal. But again, I think a lot of the difficulty people have with tapering on to buprenorphine is that unless you're doing the Bernays method, you're going to start developing worsening withdrawal fairly rapidly, right?
Right.
From your fentanyl. And so people will be like, oh man, every time I'm like going into withdrawal, I start to take the subs and then I feel worse. That's not necessarily precipitated withdrawal. That's just your withdrawal getting worse. Yep. And so what happens is, and I've had this happen with some of my patients, is I'll try and explain the method of tapering and they'll be like adamant, I don't want to use any more fentanyl anymore. I'm like, okay. That you might have a withdrawal syndrome with this as you're tapering up, and I'll give them the withdrawal management medications. We use things like clonidine and hydroxyzine or cyclobenzaprine, other medications depending on what sort of symptoms they get, Zofran for the nausea. And I'll say use those to manage the withdrawal as you're coming down and start loading yourself with the bupe. And they'll stop the bupe entirely because they start to feel worse. And then like, well, you're just going through fentanyl withdrawal. And then they'll go back to using fentanyl because they're like, I can't handle the withdrawal. And I'm like, just you want to stop using, so like just ramp up on the bupe. Like call me, and then like we'll go over how to do this. But right, like so when I'm seeing a new patient in clinic for like an induction, I follow them up within a week, and then once they're stable, we go to every month. but I'll do a week, and then if they need another week, and they can all call me during that week if they're struggling. But I'll follow up with patients sometimes at a week, and they'll be like, I'm still not on subs. And I'm like, what happened? And they're like, oh, I was just going through terrible withdrawal. And I'm like, well, yeah, you stopped smoking fentanyl, and so you're going to go into withdrawal.
So where I'm seeing this a lot too is it's not even just the clinics, it's detox facilities.
Yeah.
And I don't think detox facilities have any idea of how any of this works.
So here's something that will blow your mind. 70% of detox facilities in California, at least, don't have a medical director or prescribe medication-assisted treatment.
Wow, that's a golden standard now for treatment.
It's gold
correct?
standard. We still fund out-of-state funds these facilities that don't provide the gold standard of treatment for substance use disorders. That, like, I could talk for another hour and a half just about how frustrating that is.
I know you could. Yeah. I know.
But so when you're talking about like they don't understand this, they absolutely don't understand this. And a lot of the places, right, historically, we've had detox facilities and we've had like residential rehab where people are just maintaining sobriety without medication. And so a lot of the places still have that culture, even if they now provide MAT or they now have a medical director who will prescribe it. A lot of those places have medical directors who don't really understand this stuff. And if they do, the nurses that are there, the MAs or the LVNs don't understand how to recognize withdrawal and manage these medications because all of this is still so new to them. Because so Oregon, I used to live there. I used to work in Portland. Oregon passed a law that requires every residential rehab facility to have a medical director and prescribe MAT. So, but that just happened. So they're just getting used to this. And so eventually it will improve. This is like one of the things that I obviously feel very passionate, like that we are treating people terribly who are just trying their hardest to get into recovery. Yeah. And we're failing them.
It's deterring them. It's making them go backwards.
We don't accept failing people when they're hospitalized for heart failure. Why do we accept failing people who are trying to get into recovery? Like, it blows my mind, but all of this goes back to historical precedent and the fact that we're unwilling as a society to recognize this as a treatable disorder and that we can use substitution therapy. I mean, we literally made substitution therapy illegal in 1914, or I think it passed in 1915, but still, those things frustrate me deeply. But yes, that is likely what you're saying at the detox facilities. It is probably because they don't understand how to do it. And I will say this, back in the heroin days, as it were, and I feel old saying that, right? When I was in the emergency department, San Francisco General, we had a lot of people who were like injection heroin users. Yep. And they'd come in and withdraw, and they knew the drill, right? They come in, they wait till they were in the withdrawal, and they'd be like, I want to get on bupe. Boom, done. We all got X-waivered in my program, right? All of us could give and prescribe bupe. And that is how I got radicalized. That is how I changed my perspective, because I would literally, people would come in looking terrible, feeling terrible. You give them 8 milligrams of bupe in like within half an hour. That is how the time of onset. You would see that become a fully different person. I mean, that may not have been a sufficient dose, but then you give them 8 more or 16 more or 24 more if they really needed. But I don't think I ever really did that back when it was all heroin. And immediately felt better, right? It was not hard to get people onto it. It was not hard to like get them stable. And you'd be like, oh, cool. Within an hour, I got you stable. I got you onto the right dose, and I'm going to prescribe you a month's worth of that dose.
I love that. So many emergency room doctors, I've been there, oh, I'm sick. I've never had that experience. But How do you deal with the stigma when you're at work? Because I know, as somebody in recovery, when
Yeah.
I don't like going to the emergency rooms. I will
Right.
die like at home
Yeah.
because of how they treat me. We get treated
Yeah.
differently.
Yep.
Absolutely. Absolutely. And I loved where I trained at, San Francisco. So there's that factor. And it was in a system that the culture was based around this idea of harm reduction and
I
around
love
like,
that.
right? We all got X-waivered as residents. Even some of my attendings weren't X-waivered because they didn't want to do the extra training that they would, didn't get paid to do. And so they would like come to me or they would come to another resident and be like, yo, you have an X waiver. Can you prescribe this person, bupe for a month? And they didn't have to because there were always residents around to write the prescriptions, but we all got X waivered. All of us, like as all of the residents I still work at UCSF in the emergency department because that's my home base. That's where I love it. All the residents were up until they don't need to be anymore. But everybody who started before this year all had X waivers because that was the culture of what we did. And so now I go out into the world and that's not the case. And it was eye-opening, frustrating, disheartening. I moved to Portland after residency and went to OHSU, working part-time there. And this is not a knock on OHSU. I really love OHSU and have a lot of deep appreciation for them. But when I started there, the culture where I was with all of us used to this sort of protocol, it's like you start somebody on 8 milligrams while they're in significant withdrawal. So I ordered 8 milligrams for a patient who was an IV heroin user and she was actually IMing at this point, had a severe abscess. And I was like, how do you want me to go about your pain management? I can load you up with opioids because it's going to be painful. Or if you don't want to use opioids anymore, I can start you on bupe because she was in withdrawal at the time. She desperately wanted to stop. I tried to order 8 milligrams from the pharmacy and they were like, we don't give more than 4 milligrams at a time. You have to wait an hour.
Control. They control the doctor.
Well, and so it blew my mind and I just about walked down to the pharmacy to like strangle the pharmacist, be like, you are a pharmacist, you know how this works. And waiting an hour doesn't make any sense because the onset time is half an hour. Like, you are killing me. So anyways, that frustrated me enough to meet with the chair of the department and a hospitalist who was also interested and develop a protocol for doing inductions on buprenorphine in the emergency department at OHSU.
Thank you.
Yeah.
I love that.
And the hospitalist she was so cool. She's no longer at OHSU, but she was like, I have been wanting to start a bridge clinic for the patients that we see who can't get into outpatient treatment.
That's awesome.
So it just was like
more stuff like that.
A coincidence of, incredibly aligned people and circumstances. And so I started the ED induction protocol where we then sent people to the bridge clinic, and then she found somebody who had an outpatient clinic who could then directly accept the patients. So she was only, had to like stabilize them for a week or so, adjust their dose, etc. But it was amazing, and it's still the case at OHSU today. And so that was within a year or so of being out of residency. Wow. And that was what started the wheels turning for me of like, oh, I should just do this job. Like I this is what I'm passionate about. That was one of the most rewarding projects to me. And so it was like, okay, well, let's go make this better in other places. And then I had the opportunity coincidentally, randomly to like be on an inpatient treatment to help start the inpatient addiction medicine service at UCSF. So getting to sort of see the entire continuum of care and both learning, but also working to improve the care. And it's not just improving it because like I know better or my colleagues who are also on the service like know better. And we've talked about this. Our goal when we started the program, kind of like I say to the residents when they rotate with me, it's like to put us out of the need for a service, because everybody should understand how to do this, and it's not super difficult.
Absolutely.
And so it's the goal of that is to fight the stigma around some of these meds. Like I'll get consults and it'll be like, oh, well, you know, this person had like, it's like people just throwing their hands up and being like, oh, well, they have an addiction, just call the addiction service. And I'm like, they're already on methadone. Like you just give them their methadone. Like, I don't know why this is difficult. Like,
now, what are the doctors?
140 milligrams of methadone. They're like, well, I'm not comfortable with that dose. And I'm like, that doesn't matter. They're stable on it. Like, just give it to them. And they're like, oh, well, addiction medicine said give them 140 milligrams of methadone. I'm like, you guys you're killing me. Like I mean, whatever. It makes my day better. I get to talk to patients and get to help support their care. But like, it literally, I'm like, the fact that people have substance use disorders is not in and of itself a reason to call me. I want to be able to help them. I want to be able to help medically manage them. And like the medically complex, oh, they, you know, smoke 5 grams of fent a day and we're having a really hard time managing their withdrawals. Like, sure, love that. Happy to do that. But though, like the calls of like, oh, hey, this guy's on methadone. You're like, I'm not sure I understand the question.
Some people are asking in the comments about gabapentin. I keep saying it, and I just wanted I know we're short on time as well. We don't want to take the rest of the day.
Whatever.
Yeah, if that can be the last thing, the gabapentin, everybody always struggles with what actually helps, because there are all these things that help, but not what actually does.
So let's talk about gabapentin. Gabapentin, I mean, I don't want to spend way too much time because I'm probably running over your time. I don't care about my time. I'm good. I love talking about this. But so gabapentin is essentially a synthetic form of GABA. GABA is what your GABA receptors are activated by or occupied by alcohol, benzodiazepines, barbiturates. So a synthetic form of GABA is acting in a similar manner to other sedatives or depressants. So they downregulate the responsiveness of nerves, which can include to painful stimuli. Obviously, that is where some of the side effects, or what really are the effects of GABA, occur, because it's not unlike opioids where the mu receptor is responding to pain. GABA receptors, and it's a little more common. There are multiple subtypes of GABA receptors, but if you are giving a synthetic form of GABA, it is acting to activate the downregulation of signals, if that explanation makes any sense. So you're turning the volume down on the nerves, which is what makes it good for seizures, because seizures are, essentially a bunch of excitatory activity or increased activity in your brain that like goes out of control and takes over an area of or your entire brain. Turn the volume down on the nerves, that won't happen at adequate doses. If it will treat nerve pain, because if you turn the volume down on the nerves, that will help reduce the amount of pain experienced from the nerves. The other effects are that it causes some level of sedation, sort of like grogginess, or people talk about brain fog. Like, yeah, if you get brain fog when you drink, you're going to get a little brain fog when you use gabapentin if you use a high enough dose. Sometimes that high enough dose is the dose that is adequate to turn the volume down enough on the nerves to reduce the nerve pain. Now, people including doctors and pharmacists and prescribers in general don't always understand what this medication does and how it works and why we use it. And there's all this pushback against opioids. So it's like, oh, well, this thing works for pain, so let's use that. Yep. So that is where the gabapentin overprescribing comes from. It's this it's part of the pendulum swinging against opioids. Buprenorphine.
I was prescribed it for anxiety, off-label for anxiety.
It actually, so we do use it for that because, again, you turn the volume down on the nerves, and anxiety is like overstimulation of your nerves.
How do you get off of it? Because that's the common thread. Like, if somebody came to you and said, I'm hooked on gabapentin, what can I do?
Yeah, so this gets to the dependence versus substance use disorder dichotomy, because generally speaking, people are not developing substance use disorders that are specifically gabapentin use disorder, right? It's not really a thing that doesn't, is not yet identified as a distinct addiction entity. Can people become addicted to literally anything? Sure, if you don't have control over your use and you are using more in a way that is harmful to you, yeah, kind of like by definition. Is that a widely spread or widely recognized disease entity? No. Can you develop dependence and tolerance to it? Absolutely. So you increase the dose over time, and because like alcohol, right? If you were to drink, like if I were to drink a fifth of vodka right now, like I would probably die. If I did that gradually over time, where I developed a tolerance to it, I could probably do it. If I stopped immediately, I would have very severe withdrawals. Similarly, gabapentin, you gradually increase the dose over time, you develop a tolerance to it, and then you develop withdrawals if you stop it. So getting off of gabapentin is going to mean tapering down, first of all, and then potentially using adjunctive withdrawal management medications. So one of the ways you can do that is either through other GABA activating medications like benzodiazepines, preferably like long-acting benzodiazepines. We're talking like Valium or Librium.
What if you've had an issue with benzos though? Because
If
like
you've had an issue with benzos
I can't take
and you are
benzos.
on gabapentin, so there are other things like clonidine, hydroxyzine, that they are not specifically GABA, what we would call GABAergic or GABA activating, but manage other receptors that are part of the withdrawal syndrome that are activating. So if you have a depressant, your withdrawal syndrome is becoming activated, right? And so you take, to manage that, you use things that are decreasing the level of activation. The opposite of the depressants is going to be essentially forms of adrenaline. So adrenergic receptors. And so one of your adrenergic receptors, there's alpha and beta. Clonidine blocks, is sort of like a double negative, but clonidine is acting at the alpha receptors. And so you're blocking that. And then there are also, like I said, beta receptors, other things that are binding to that these adrenaline molecules are binding to. If you can start blocking those, you are still having the withdrawal syndrome, but your body is blocking that response to it, if that makes sense.
So it's not going to be as harsh on your body.
Right. So substitution therapy would be like benzos. If that's problematic for you, which it is for a number of people who are on gabapentin, say for anxiety, then using withdrawal management medications is your alternative, where what we're saying then is we are expecting your body to be physically going through a withdrawal syndrome, but we're going to manage that syndrome by blocking the receptors that cause the feeling of withdrawal that you experience.
Cool. Thank you very much for coming
Bye
on.
guys. Thank you.
Bye everyone. Thank you.